So welcome everybody. My name's Jan. I am Executive Officer for the charity Give a Kidney. I think some of you will already know me, so welcome to those of you who do, and lovely to have those of you who are maybe new to the charity joining us today. And welcome to our webinar, Ask the Experts, which is a chance for anybody who's interested in living kidney donation to have expert advice from our panel, who I'll introduce shortly. For those of you who don't know Give a Kidney, we're a small charity based in the UK. We are the only charity that specialises in living kidney donation in the UK. So we have three strands to our work. We aim to raise awareness of living kidney donation, to support people who are going through the living donation process or have been through the living donation process, and also to influence kind of positive change in the living donation sphere. So we've been in existence since 2011, and many of you have been supporters of us in the past, so thank you for that. I'll introduce our panel. We've had a slight change to our panel today just because of a technical issue. So Sarah, who was going to join us, unfortunately hasn't been able to. We're here, hope she'll be able to join us for the next one. But we are delighted to be joined by Lisa Banap, Adnan Sharif, and Chair of Give a Kidney, Bob Wiggins, is also going to sit on the panel today. So in fact, I'll ask you now if you don't mind introducing yourselves, and we can go from there. So I'll start with you, Lisa, if that's okay.
Good morning, everybody. It's always a pleasure to be part of these webinars. I'm Associate Medical Director at NHS Blood and Transplant for Living Donation and Transplantation. But most of my career has been devoted to living donation in some form or other. It's been a great pleasure to collaborate with Give a Kidney over the years to try and improve things and reflect the views of people who are wishing to donate or who have donated. So it's a great pleasure to join you this morning. Thank you, Jan.
Thank you, Lisa. Adnan?
Morning, everyone. My name's Adnan Sharif. I'm a kidney consultant here in Birmingham, and I've been involved with Give a Kidney now for probably over 10 years, originally on the steering committee and more recently as a trustee. So I'm very happy to be joining you this morning.
Thanks, Adnan. And Bob?
Yes, Bob Wiggins. I'm chair of the charity Give a Kidney. I donated my kidney to a stranger in 2013. And since then been very involved with really everybody here over the years in one form or another in raising awareness and supporting donors.
Thank you. Thanks, Bob. And thanks again to you all for giving up your Saturday morning. It's very much appreciated. So just a little bit of kind of housekeeping, really. Yeah, we've got some people coming into the chat already, so I hope Anne's been able to access and join us. And Lynn, no, we won't be able to see or hear you. This is a Zoom call, so we'll only have the panelists on screen. But you will be able to submit questions to the panel through the chat function. Thanks, Lynn, or through the Q&A. We'll probably use the chat function, I think, since people have already started putting things into there, and that's fine. So if you have any questions that you'd like to put to the panel, just type them into the chat. I'll do my very best to keep tabs on that and put your questions to the panel. So obviously we've got a variety of experience here. I'm also a living donor as well. I donated back in 2013, so I also have some lived experience of donation. But we'll kind of start with some questions that we know kind of come up quite a lot, and then hopefully people will feel free to ask anything you would like to ask. Just to kind of give a bit of a caveat, we won't be able to give you specific medical advice. We can give you generalized kind of advice, or talk about the general policies. But obviously, if you have a very specific medical question and you're thinking about donating, we will be directing you back to your unit or to your living donor coordinator if you're at that point. But in general terms, we'll be able to hopefully offer some answers to anything that you want to ask. So I think that's everything. Just one thing around terminology. Many of you will be familiar with terminology around living donation, but some of you may be very, very new to this. So you might hear some phrases or words that are unfamiliar. So we just kind of go through those now, which are around the different types of living donors. So you might hear the term non-directed living donor, which is somebody who donates a kidney to somebody they don't know, so anonymously to somebody on the waiting list. Directed donation is where somebody donates a kidney to somebody very specific, perhaps a loved one, family member, friend. And there is another category called non-directed directed altruistic, which is where somebody donates to a very specific individual, but one with whom they have no prior emotional relationship. So that might come, for example, through an appeal on social media or through the media where people are asked to step forward. So they're donating to that particular person, but they don't have an existing relationship with that particular person. If as we go through there, we use any terminology that you're unfamiliar with, just put that in the chat and we'll explain that if you've got any questions about that. So please don't hesitate we want this to be an interactive session. So please, please just pop questions in there. So we're just going to kick off really with a question that we're kind of often asked at the charity, which is why do we need living donors? And will that change now the opt-out legislation around deceased donation has come in? So I don't know, Lisa or Adnan, whether you want to start with that question. Shall I go to Lisa? Oh, Adnan, thank you.
Oh, I've unmuted. I mean, I'm sure Lisa and I would probably give the same answer to this. I mean, unfortunately, there is still a gap in the supply versus demand for kidneys, and the kidney transplant list is still probably at the highest point it has been for quite some time, and certainly for children on the waiting list as well. It's one of the highest points, and despite all the innovation, all the legislation to try and boost living donation, to try and boost donation after death, unfortunately, there is still this gap. So it's really just a question that there's not enough donor kidneys, either living or deceased, to meet the demand. And that's because kidney disease and kidney failure are becoming major public health burdens.
Thank you,
I
Adnan. Oh, sorry, Lisa.
totally agree. No, totally agree with everything Adnan says. I mean, we're sadly in a very difficult position at the moment, and so every donation is incredibly precious. But also, I would just add, in addition to that, living donation has a unique place in our kidney transplant program because of the contribution to the kidney sharing scheme, the way in which people just volunteering to donate to someone they don't know in that way can trigger a sort of a chain reaction through the kidney sharing scheme, where where you donate to somebody and then that frees their donor up to donate to somebody else, and that is an absolute game changer in the kidney sharing scheme. So I would say absolutely, please, yes, please, we need your kidneys very much indeed, and all offers of donation. So thank you.
Thank you, Lisa. And I think it's the figures are kind of startling, really. The stats are that 6 people a week die in the UK in need of a kidney. So it is hugely needed and likely to become more so, I think, in the future, are the projections, sadly. So hugely necessary. So are there any restrictions in terms of who can donate, in terms of age?
I'll start with this, but I mean, essentially, no. There's apart from some very kind of clear red lines, no, there are no restrictions, and certainly age is just a number, both for donation and for the person receiving the kidney, and there is no age cutoff in either donation or transplantation. But clearly, the older we are, the more health issues perhaps we may have. So it just requires a very careful review. And my job as a kidney specialist, when any potential donor comes forward, is to go through their health issues, their risk of getting kidney disease themselves, and every single donor is an individual. But no, age by itself is absolutely not a barrier.
Thank you. We've got someone in the chat saying they were 75 when they donated, and there've certainly been donors in their I think the oldest one is 86 or 85, somewhere around there. So yes, absolutely, it's yeah, really important, and there's somebody who could use that kidney as long as it's healthy enough. So, and what kind of difference does a kidney make to somebody, Adnan? Somebody who's
I mean, it makes a phenomenal difference. I mean, I look after kidney failure people, so I do look after people who are on dialysis, but I'm mainly a transplant consultant. So the most amazing thing from my point of view is when one of my patients who I look after on dialysis makes that journey and gets their transplant, and you can just see the complete change in them. So the major things is that it's the best form of treatment for kidney failure. It's important that, it's not a cure. Transplantation is not a cure, but it certainly is the best form of treatment. So transplant patients will live longer. They live with a much better quality of life. It also is the cheaper option for the NHS, an important consideration. Transplantation compared to dialysis saves a lot of money. It's also the greener option as well, if you think about all the water and all the plastic that's used. So it's I always kind of often say that there's not many things in the NHS which make people live longer, live better, and saves money. And I think kidney transplantation is probably one of those things. So it makes a big difference to patients who live with kidney failure.
Thanks, Adnan. And maybe this is one for Lisa, but could you talk through the process that somebody, very briefly, if somebody was interested in living donation, the process they would go through to become a living donor, please?
Yes, certainly. I think this can be a little bit daunting, can't it? I mean, if you're not familiar with something, it's very difficult to sort of think, where do I go with that? So what we try to do is to provide information for people in different ways, because everybody processes things slightly differently. So we do have our own website in NHS Blood and Transplant, and that's a really quite a good place to go first of all. There's a 3 Ws, organdonation.nhs.uk, and if you go to there, there's a tab that says become a living donor, and that will guide you through whether or not you're thinking of donating to somebody directly, somebody in your family or a loved one, as Jan said earlier, or somebody you don't know or have never met. And there are different pathways you can go through there. There's a short film series that you can be guided to, and there's sort of web-based information. And now that's really just a shop window, and there are lots of other places you can go. I mean, the Give a Kidney charity has always been a mine of information, and that's sometimes a more comfortable place to start, with people who you feel have gone through the donation process, and you can ask what you think might be the obvious questions. There's no obvious question. There's no stupid question. Everything really is for you to find out for yourself, because everybody's an individual. And there's also, of course, which I'm sure Jan will talk about, that Give a Kidney participate very closely in the Dangle partnership now, the Dangle programme, where they have literally set up a whole system to introduce people who are thinking about donating to the idea of donating, to support donors through the process. And that's very well worth getting in contact with as well, because that's a kind of softer approach. But if you feel really confident in the research that you've done, and many of you I know you'll research this wherever you can find information, then you can contact the Living Donor team. Now, the Living Donor team, every transplant centre has a dedicated Living Donor coordinator team, and they are there for you. Whether you're donating to someone in your family, a friend, or someone you don't know, that is what they're there for. It's a whole job. And I can tell you that with absolute clarity, because I did that job for many, many years. And they will also be very willing to talk through with you in some detail your specific situation, because, as I say, everybody's an individual. So the first thing I would suggest you do is find out the information. If we're not answering your questions either, because website information and so on is often quite general, but if you will have specific questions about your medical history, your circumstances, your recipient's circumstances, so that the point of contact really is the Living Donor coordinator team. And then from there, they will talk through with you. They may do some initial assessment for you. And then there'll be a whole process of incredibly rigorous assessments, seeing people like Adnan, who will look at all the medical aspects for you, seeing our surgical teams who will obviously talk through the surgery, the nature of the surgery, which kidney you would be best for you to donate given your particular tests and so on. So it's an extremely rigorous process. Importantly, at the end of that process, there's a legal requirement that the donor, anybody donating, has to meet approval that they have the claimed relationship or not with their recipient, that they absolutely understand and can give free and voluntary consent, what's involved for them. And that's a requirement of everybody. And you will be interviewed by somebody called an independent assessor. And then that goes to the Human Tissue Authority for approval, and then our surgeons can legally operate on you. So there's quite a process. You'll find it's done slightly differently wherever you are, because every team will have its own way of working. But hopefully that process is something that will take probably months, but you can discuss the timeframes that are important for you with your coordinator team, and they will be there for you throughout. So I suppose the key messages are you have key contacts in the transplant centre or in a centre that refers donors and recipients into a transplant centre. That's through your living donor coordinators. You'll develop key relationships throughout the assessment process with the medical team, with the clinical team, and you also have all these fantastic resources in charitable partnerships around you to support you. So please do use those, and hopefully that will give you the reassurance to pick up the phone or write that email and make contact with us. I hope that's helped, Jan.
Thanks so much, Lisa. Yes, and I will just pick up on the Robert Dangor partnership that Lisa mentioned. So Give a Kidney, together with Kidney Research UK, another UK charity, have been very generously given funding through Dr. David Dangor and the Exilarch Foundation to run a 5-year programme to support donors and raise awareness of living kidney donation. So Give a Kidney and Kidney Research UK have now established that programme. It's now set up and running. There's a new website, which is www.donateakidney.co.uk, where you can find lots of information, also on Give a Kidney's website. But we have, as Lisa said, we have two things. One, we have a relationship manager, Jenny, who is just at the end of an email or at the end of a phone, and can help anybody who is kind of just at the very early stages of thinking about whether this might be something they want to do. She can help point you in the direction of resources, can answer the questions that you might have, and really guide you through the journey to your transplant centre. So she's there, she's full-time. We encourage people to contact her. She's very pleased to hear from you. And she can also, so just before Christmas, we launched together the first UK-wide living donation buddy support service. So this is where it's an online portal where you can be matched to another living kidney donor or friends and family of a living kidney donor who can share their lived experience with you. So thanks for adding that link in the chat, Bob, to the website there. And you can select your buddy by gender, by age, by geographical region, by ethnicity, by religious belief, by geography. So you can find somebody who might have been in a similar position to you, and they're really just to share their experience of what it was really like as a donor, or as a loved one of a donor, because obviously that can be a difficult thing, that family members can find it very difficult to see their loved one who doesn't need surgery going through surgery, and we'll maybe come back to that. I know there's a question about directed donors in the chat already. yeah, it can be a difficult thing. So we recognise that family and friends may also need some support and maybe reassured by somebody else who's gone through that process and come out the other end. So, so do get in touch with Jenny. Have a look at the website donatekidney.co.uk. It's a programme that we're very proud to be part of, and working very closely with the clinical community and NHS BT, of course, as well. So yeah, that's a good starting point if you're just at the point of thinking about donation. And equally, we also invite people to come back after their donation journey to share their story and raise awareness for both the charities as well. So there's often, and we will come to some of these questions shortly, but I think one of the things we're often asked about, which I think it probably is worth covering here, which is about the risks of living with one kidney and the risks of surgery. So, Adnan, are you happy to take that one?
Yeah, sure. So it's fortunately it's kind of a very low risk procedure, but it's clearly not risk free. It is surgery. It's keyhole surgery. And my surgical colleagues now been doing this surgery for over 50 years, and so fortunately the risks are minimal. And there's the risks associated with the actual surgery. But although most donors are usually going home either the very next day or the day after, but clearly everyone's an individual and things may be slightly different for people depending on age or some other factors. From a medical point of view, the long-term risks, we now are fortunate that we've got data going back many, many decades from around the world. And what we counsel most of our donors is that the medical risks associated with living with one kidney compared to two is that their blood pressure may go up a little bit. Again, some studies suggest there's not much difference in the first 10 years, but we do counsel donors of that possibility. And the one remaining kidney, because it beefs up how much work it does, and sometimes you can have a little bit of protein leak in the urine as well. The drop in kidney function that happens because obviously you give away one kidney, as I mentioned, the other kidney kind of increases in size and strength. And if you actually were to scan the remaining kidney, I think in the space of about 6 to 8 weeks, it's actually got a little bit bigger because it just takes on that extra work. And what we know is that after that kind of drop in kidney function, when you go from 2 to 1, you actually get kind of an improvement over time, and that actually stabilizes in comparison to, say, healthy non-donors. There's lots of data now that there's no increased risk for things like heart problems. And in the long term, the survival for people who've donated the kidney is better than the age-matched people in general population. And the reason for that is because to be a donor, essentially, you have to go through a very vigorous MOT and pass. So to be able to donate, you have to be fitter and healthier and as kind of low risk as possible. And that fits in a little bit with the time frame that we've spoken about that it takes to assess donors. As much as we want to have that process as timely as possible, we need to make sure that safety comes first. And as much as I've kind of said, the benefits of donation, especially living donation to my patients who live with kidney failure, we always say to people that as much as obviously I want the person who's going to receive this kidney to come off dialysis and get the transplant, the priority is always the well-being of the donor. And that's really important for people to understand. And there may be lots of questions about, I have this health issue, I have that, can I be a donor? And everyone is an individual, and there's 1,001, there's probably 1,000,001 different kind of combinations, and it's very hard to kind of give very detailed explanations for who can or can't be a donor. But you just need to speak to the medical and nursing team. And as much as we are very keen to support your wish to be a donor, be reassured that our overall wish is to make sure that your well-being comes first. And if that means you can be a donor, wonderful. But if that means that we sadly have to say that you cannot be a donor, just be reassured that that's because the donor's interests always come first.
Thank you, Adnan. And maybe we'll just take around this question because there's a couple of questions in the chat. So one is from Anne. Thank you, Anne. Can partial kidneys be used for multiple donations, like the liver, for example, which a piece can be taken as for a donation?
But I mean, I'll quickly take that. Sadly, I mean, the kidney is clearly the most important organ in the body, as I always tell my liver colleagues. And here in Birmingham, we do kidneys, livers, heart, lungs. But unfortunately, on this, the liver does trump the kidney. The liver has kind of special regenerative powers, and it's clearly quite an amazing organ after the kidney. But no, unfortunately, we cannot cut a kidney in half and transplant it. We do sometimes, my surgical colleagues may take a kidney that may have a cyst or something like that, and they can remove a small tiny part of that. But unfortunately, no, unlike the liver, the kidney can't be split into two. Nature's given us two for reasons which are not particularly clear, because clearly you can perfectly live with one. So I guess that's where the kidney trumps the liver, that we've been gifted a bonus one.
Thank you, Adnan. And there's a question in the chat about, and I don't know the answer to this actually, Adnan. I don't know if there is a clear answer, but there's a question about this person, Lynn, I think, was a non-directed donor and was asking about where can we find information on what drugs or vitamins we should not take. I think there's sometimes advice about ibuprofen and other, but is there anything else that we should be aware of as donors?
I mean, that's a really good question, because actually that, for a lot of our patients who have kidney disease, I mean, it's a very common question for them. And you're right, there's no easy resource available which provides any kind of caution. I have to say, for most of our patients, and especially for people who've donated, I do say that, I mean, there actually aren't any absolute red lines for what you can't take. I mean, yes, ibuprofen to a kidney specialist like myself is like kind of garlic to a vampire. I think just a mere mention of it, and I shudder, and I think it's banned in my household. But fundamentally, what we will often say is that there aren't any drugs or medications that you cannot have if your kidney function is okay. What we do say is that if you do need a painkiller and paracetamol is sufficient, I would go for the paracetamol rather than the ibuprofen. But if you really do need to use things like ibuprofen, it is okay. You don't need to be too worried. I think it's probably kidney doctors like myself that kind of put the fear of God into people about ibuprofen. But because we see the sharp end of people who often do sometimes have problems, but often those are people who've taken ibuprofen when they have a very, very, very low kidney function. And hundreds of thousands of people take ibuprofen on a weekly basis, most who we have no idea about because they pick up with their weekly shopping. So I think with regards to what you can take, really you can take anything, but it's always worthwhile maybe just discussing that with either your GP or a healthcare professional. But there isn't anything that you absolutely cannot take, unless of course your kidney function is very, very low, which for the overwhelming majority of our donors, that isn't the case.
Thank you, Adnan. I hope that's answered your question, Lynn. Let me just have a look what else is coming in. So should we just talk a little bit about recovery and the recovery after surgery? And Bob, I wondered maybe we could bring you in here and ask you how recovery was, how it really was from a donor perspective. We've got somebody who said, I think they're donating quite soon, who's 75. So yeah, it might be interesting to hear what your experience was of being in hospital, surgery and recovery afterwards. And obviously everybody's different, so we can only share, Bob will be sharing his own experience, but yeah, good to hear from you. Thank you.
Having discussed this with a lot of other donors, it's clear that experiences vary quite widely. So any one person's experience may not be shared by anyone else in particular. I was fortunate My stay in hospital was short. I went in on the Wednesday morning, and I was home by lunchtime on Friday. I was up and around within a few days, doing short walks. I recovered quite well. I was never in what I would call pain, but I was certainly had discomfort, if I can phrase it that way, from where the operation took place. And my most painful moment, there are two, I guess. One was I missed a step on the stairs as I was going upstairs shortly afterwards. That was a reminder that I needed time to recover. And the second one was the journey home, which, if you look at what a lot of people advise, the hospital, if you take a pillow with you and hold that around your middle section, it makes the journey a lot more comfortable than otherwise. The aftercare was fine. I had the checkups, the routine checkups, all went well. I have an office job, so it wasn't like I had to take a lot of time off work. I probably took about 3 weeks off and then eased back into work. So it went very well. But I guess in our role at Give a Kidney, we become aware that there are, we talk about risks, and some people may develop an infection which can be controlled by antibiotics and clears up not long after. Some people are more sensitive to the pain than others, but it is relatively short-lived, and some require a longer recovery period. So I don't know if there's anything specific I'm missing, Jan, that you want me to probe. I count myself as quite fortunate through the process. It was never difficult for myself.
And you're kind of 10, 11, 12, nearly 12 years on now. And how is your health now? Have you noticed any difference? Did you notice any
No.
changes to your
No, I abuse my body as much now as I ever did before. I eat the wrong foods and I drink the wrong things, and so it's made no change. Of course, I have regular checkups, and my kidney function has been steady throughout. So no ramifications then. And quite honestly, I forget that I only have one kidney. It's just not something I think about on a day-to-day basis. The only change that I've made is I do try to avoid ibuprofen. But I understand from nephrologists and others that everybody should avoid ibuprofen if they can. So there's no difference there. That's about it.
Thank you,
Jan,
Bob. Yes,
Could I just add? I think I mean that's probably quite typical, actually, Bob, of what we would expect and hope to see. As you say, there are some people who might be the edges of that and have a particular thing that slows their recovery down. I don't know whether this is helpful to throw in, Jan, but what I used to say is, if you're, and Adnan may wish to refute this, but I think you need to give yourself those first few weeks. People go into this as healthy individuals, and then you may never have had something as large as this in terms of surgery. And we have to be honest, it's major surgery, isn't it, having a kidney removed? So you're going to hit the ground, and you have to be prepared for that, and then give yourself the time to recover in those early weeks, because if you go too fast too soon, then you're likely to put yourself back. It speaks for itself. Just listen to what your body is telling you. You will feel tired. You will feel the effects of having been in hospital and gone through not only a physical, but also an emotional experience as well. And that will take people in lots of different ways. So I would say, roughly speaking, if you're in a desk type job, and around 4 to 6 weeks, many of my colleagues would say 6 weeks, but a lot of people might feel able to go back on a phased return around 4 weeks. If you're in something much more physical, so you're in a very physical line of work, I would say be prepared to give yourself up to 3 months, because I think it does take that sort of time to get your physical, sort of capacity back up, because it goes quite quickly. But that is a rule of thumb. And we tend to err on the side of caution as healthcare professionals because we don't want people to go at it too quickly. But I would say give yourself the time and be kind to yourself around that time. And I think in the long run, what I see is then people do better because they don't stumble up the stairs, Bob.
Just to quickly add in, I completely agree with everything Lisa said. The danger sometimes with living donation is that people go home day one, day two, and they feel great, and that we kind of try to reassure them. We just tell them exactly what Lisa said. There's a look. Just you need to give yourself a little bit of time to just rest, because the problem is they'll feel, oh, I feel fantastic, and I'm just going to go back to doing all the regular things. I'm going to carry the heavy washing upstairs, downstairs, and then you'll run into problems with hernias and things like that. So we do say to people, just take some time. Again, work, we do say completely what Lisa mentioned. We normally say 3 months. And that's definitely the case for physical jobs. For a lot of people, they often because they'll have lots of follow-ups with the life donor coordinators, and then they'll have a follow-up with the surgeon at 4 to 6 weeks. And often people are coming in and saying, oh, I'm just getting so bored. Can I please go back to work? And normally then the surgeon will say, well, look, as long as it's not physical and it's desk-based, yes, you can go back. Driving is another common question that people often ask. What we often say is that, again, just listen to your body, and if you feel comfortable that you could do an emergency brake, that's the time when you can go back behind the wheel. So that may be 2 weeks, that may be 4 weeks, and of course just inform the DVLA. But it is low risk. People do recover quickly, but you just need to show a little bit of respect to the fact that, as we've said, you've had a general anesthetic, you have had major surgery, and the danger is that people feel too good, and perhaps do things which they've been told to just take easy for the first few weeks.
Thank you, everybody. And just following on, there's a couple of questions around other potential changes. So somebody asking, are they able to give blood after they've donated a kidney, and what the advice is around that? Lisa, do you want to?
Yeah, I'll pick that up. Sorry, I'm looking at Adnan. I'm getting cues from Adnan about whether he's going to do that. Yes, you can continue to give blood. I wouldn't do it immediately. I would give yourself time to recover. And actually, the blood service probably wouldn't accept you back immediately, I think. And if you are a blood donor, certainly, and I don't know what Adnan says to his donors about this, but I always used to say, give yourself a good 2 months before you're going to proceed. He's sort of nodding, so we're in accord there. Before your donation. But don't give blood within 2 months of you donating beforehand, and afterwards I think it's just got to be on your recovery. I mean, you shouldn't require blood when you're donating. Again, there can be the occasional time when you do. If you do, then that's something to talk to the blood service about, because they will tell you about the screening around that. So if everything's gone completely straightforwardly and you haven't had any blood, give yourself the time to recover, and I would say go back at that sort of 2-3 month mark and ask if you can then donate.
Thank you. And there's a comment just in the chat saying the only thing that this person noticed, Lynn, was it was a gloop as other organs slithered into the space, or so it felt. Yes, I think that was familiar. And she went back to blood donation after about 6 months, which is great. So thank you for that. And Kieran, thank you, saying, oh, my recall of most obvious post-surgery symptoms is bloating. Yeah, your plumbing's really been messed with, and it takes a few weeks to be fully back to whatever is normal for you. And you might feel some loss of appetite and discomfort. And exhaustion. Yes, I remember this. I was very tired. I think that was the overriding feeling I had. I just felt like, well, I'd run a marathon. But I guess all your energy goes into healing your internal bits that have been cut. So, but yes, I think Kieran's saying, yeah, it was unexpected even weeks later. Remember that your insides are still adjusting. Absolutely, your body's working overtime to heal itself. So thank you for those comments. And good luck, Bob, with your donation coming up. I hope it all goes very well for you. I'll take some more of these questions. So yeah, let me find it. Paul, thank you for sharing that with us. So he's saying his 24-year-old son has dyspraxic, I can't even say it, kidneys, and has had 2 directed donors who sadly have changed their minds at the last minute. Is it common for living donors to change their minds at the last minute? How often does that happen? It's a really difficult thing, isn't it? So Lisa, do you want to take that one?
Yes, and Paul, I feel your pain. It's really hard, isn't it, when you're seeing someone you love and the opportunity is disappearing. Part of the process that we go through with people, when people volunteer and offer a donation, because there is quite a lot that you have to take in and quite a lot involved. I think sometimes people don't always realize in the beginning what that might entail. So there's that aspect of it. And we always give people an exit strategy. It's really important because ultimately a donor, it's terrible if somebody goes ahead and regrets a donation. So really they need to go ahead really fully engaged and committed to that whole process. So it may be, obviously, you may not be party to the reasons, and we are very clear about that the donor has a relationship that is separate from the recipient with the clinical team, and that's the coordinators, that's the consultants, and so on. So it isn't uncommon for people to withdraw and say, actually, I don't think this is for me. I don't think this is the right time in my life. There's too much going on for me. I haven't got space for this. I've got young children. Whatever their reasons are, they're their reasons and they're to be respected. There may, of course, be some really concrete medical reasons why it's not safe. As Adnan was talking, safety is our primary concern. We have to keep the donor in the center of our thoughts when we're assessing them as a suitable. We know the recipient needs a kidney, and that's our ultimate aim for the recipient, but the donor is, if you like, a patient in their own right, and we have a duty of care to them. So there may be a very clear medical or clinical reason why they're not suitable to go ahead. And the other thing that we do is to respect the privacy of donors. So it is really difficult if people do feel that they've got cold feet about the process and they don't want to proceed to know how to say that. And so you may not know why they have withdrawn, because that's something that we commit to them to say. But actually, if somebody in their head is not committed to the donation because it's not right for them, whether it's a medical reason or it's just not right for them, they're not a suitable donor. And it's much better that that donation doesn't proceed, because there are all sorts of implications and consequences of that. So I'm really sorry about what's happening to you. But this does happen, and it's also part of the healthy donor assessment process that people have that ability. They don't feel they're on a hamster wheel and can't jump off. I hope that's sort of given you an explanation at least. Adnan may wish to add though. Adnan, you may.
Yeah, no, I mean, completely agree. And, following on from kind of what was said earlier, the well-being of the donor always comes first. And we do always explain to the donor that at any point they can stop the process, and that's it's kind of a built-in clause, just like a safety clause. And we've seen many different kind of times when people do withdraw, and sometimes, as Lisa said, it's just because they just weren't psychologically quite ready for it, and then they'll often take a bit of time, regroup, and then they come back, and people need to have that space and opportunity for them to do that. But we've sometimes had donors who have said that they can't go through with it on the morning of the operation. And again, we will respect their wishes, and we will sit and talk to them, try to understand. And often it's just anxiety or fears, but fundamentally, they always have that opportunity to withdraw. But in a lot of those circumstances, people they just need a little bit of time, they need a bit of space. this is where the use of kind of hospital psychologists becomes really, really valuable, and people sometimes just need an opportunity to have a breather and then come back into the process. But fundamentally, yeah, people will always have that opportunity to withdraw, and we always will respect their wishes, but provide whatever support we can.
Really, really difficult situation. So yeah, thank you. Yeah, and Paul's asking about the exclusion of type 2 diabetics from selection to be a donor. Can you comment on that, Adnan?
Yes. So the guidelines are actually they do allow it, but with lots and lots of caveats, and it's basically left to the doctors to kind of make that decision. I know that for many of my medical colleagues, having type 2, having any diabetes, even if it's exceptionally well controlled, I think they again, it's that overarching thought that we're thinking about the well-being of the donor, but I think it very much depends on the individual donor. So for example, we would have a slightly more relaxed view if the donor were. I've said that age doesn't come into a consideration, but this is, I think, one aspect where age probably would. So if somebody did have diet controlled diabetes, which is very well maintained, the kidney function is excellent, there's no protein leak, and they were in their 60s, for example, we would look upon that maybe a bit more favorably than someone who's in the exact same situation but was in their early 20s, for example. But it's true that diabetes for a lot of my medical colleagues sometimes can be a bit of a red line. But if that is the case, one other thing that we can mention is that you are always welcome to seek a second opinion. And you will not upset any hospital, any doctor, any nurse to seek a second opinion. And the one thing you will find is that you may see some slightly different opinions at different centres, and it's not because anyone is right or wrong. It's just that some bigger centres, for example, who have a bit more experience in doing lots and lots of these may have a slightly different view on things. But yes, I think diabetes, it very much depends on the individual. So it's not an absolute red line, but it is a bit of a pink line, I guess, if if I can say that.
Jan, I wonder if I could just add in this situation. I know we're not talking about individual situations, but clearly there's a challenge where there is a challenge in a family or a close-knit group to find a suitable donor in a situation like this. Just be aware there are lots of possibilities in kidney donation. So you've got the kidney sharing scheme, which you may or may not have heard about, which allows people who are not compatible by blood group necessarily, or may just, or may be looking for a closer match or a better age match with a donor that you may not previously have thought about or may have excluded because if they haven't got the same blood group, you might be thinking they're not suitable. So they're also, if that scheme's not suitable, there are also ways sometimes of removing antibodies if a donor and a recipient are not compatible with one another. So if those discussions haven't been had with you, it may be with anybody on this call, please go back to your team and say, look, I know there are different options, and could I just discuss some of those with you? And also, I'll pop the website address in the chat actually for the NHSBT website, but you'll find information about that there too. It's just so that, because there are lots of options and sometimes it's not the most obvious one, that if that's looking as if it's not going to be possible, then there are other things that you might want to consider.
Thank you. Thanks both. There's a question about, can adult kidneys be donated to young children? But also I think maybe I think we talked about older age groups earlier as a cutoff, but can children's kidneys be donated to other children or to adults? Can children be living donors?
Well, I'll take the first question first, then yes, adult kidneys can be donated into younger children, but there will be a what my pediatric colleagues will often do is they will look at the size of the child. So obviously into kind of newborn babies, that's not possible. And the child has to be of a certain size to be able to kind of basically take that kidney in, and so that may be kind of when they're toddlers. So it's a very kind of personalized approach, but there has to be a certain size for the child to be able to do that. And with regards to living donation, Lisa will correct me. I think the age cutoff is 18. Is that correct, Lisa?
It is, it's actually, yes, 18 everywhere except Scotland, which is 16, but that's only because it aligns itself with age of consent.
With regards to donation after death, though, children can be donors, and there, I mean, there's even cases, and I think colleagues in Leeds have done this in the past, where they've done kind of neonatal kind of donation, which is not very commonly done. So there's deceased donation, and there's no age criteria, but living, yes, 18.
And we do sometimes hear that some units are more cautious around, potential living donors who are, in their late teens or early 20s for reasons we can all imagine. So again, if you're a younger person thinking about donation, you'll be advised and counseled very, very carefully through that. And sometimes we hear that some units actually prefer donors to be that little bit older, or for women to have completed their family as well before donation. So obviously it will be done on a case-by-case basis. But again, if you're a younger donor and your particular unit is concerned about your age, again, you can seek a second opinion elsewhere. And it's done with the best of intention around protection of the donor, as Adnan has already talked about.
I'll just add in there. I think it was our transplant meeting last year where there was a wonderful debate on should young people be allowed to be living donors, and both arguments were very fair and reasonable. But I think without a doubt, my kidney colleague from Bristol, who was advocating that you should allow younger people to donate, I think one, fair and square, and I think the argument was that everyone should have that opportunity, and there's no reason why we should deny the opportunity to be a living donor to an 18-year-old versus an 80-year-old. But again, it's just going through the pros and cons, advantages, disadvantages, but everyone should have that opportunity.
Could I just add something about second opinions, Adnan? Do you mind? Is that and Jan?
Yeah.
I think this is another really daunting thing to do when you know a team, is to say, actually, I'd like to go elsewhere because you've given me this opinion, but please, I mean, Adnan's actually comment earlier was absolutely spot on. It doesn't offend any of us. We recognise it's something that you are entitled to if you wish to. You may get the same answer as Adnan said, or you may get a slightly different one. But the other thing is if you are, and I'm sure you won't, but if you were struggling with that and having difficulty with that, you can always contact us as well at NHSBT, and we can guide you to centres that may be willing to do that for you, and can work with the clinical community on that. So I just wanted to say that don't feel that isn't something that you can do, to add to Adnan's earlier comments.
Thank you. We've got a couple of questions around, I suppose, trends or developments in living kidney donation. So there was a question about the overall trends in numbers of people donating as living donors over the years. Lisa, I don't know if you would like to comment on where we're up to with that at the moment and what's happened over the last few years.
Okay, so in the UK, because when you look across, for example, Europe or the world, the donation, it comes from different sources. So as Adnan already said, we have people who donate after their death. And that's still where the majority of organs come from, is people who very kindly sign up to the organ donor register, and are, have not opted out of our current system. And that's still the greater part of donation. Living donation makes up around 28% of all kidney transplants a year. But if you look across all donors, because obviously living donors only donate one organ, actually it's about 40% of all donors. And non-directed donation in this country is absolutely phenomenal in comparison with other countries. In each of our quarterly matching runs recently, we've had more than 20 non-directed altruistic donors register to be part of that sharing scheme, part of our national programme, and offering their kidneys to anybody. And that is phenomenal in comparison with other countries. And we know how much difference, as I said before, that those people make. So that's really something that that everybody who's done that should feel very proud of, and the charities who've supported that. So in terms of living donation, we're not the highest, but we are one of the larger countries in terms of a living donor programme. And part of that is because we've worked very hard, as Adnan said, for many, many years to improve both the rates of deceased donation and the rates of living donation at the same time. So I think, as it's described by a previous colleague of mine, we're trying to be the best at everything. So there's going to be some flexion around that. What has changed is how people donate as living donors and the opportunities we can create through living donation. So with the sharing scheme, the kidney exchange programme I talked about, with our non-directed altruistic donation, and the other things that allow us to remove antibodies for some patients against blood group or tissue type, HLA antibodies, as we call it, that allow a transplant to go ahead as well. So all of those things have contributed. So it's around about a third of what we do. And increasingly, we're also now focusing on our liver patients who need a transplant as well. So I hope that's given you an idea. What I should say to you is, very disappointingly at the moment, our deceased donation rates are not where they were since the COVID pandemic. And a lot of that is around the discussions with families at the time of death. So that's very sadly having quite a big impact on our deceased donation rates at the moment.
Thanks, Lisa. And I don't know, Adnan, Karen's asked about commenting on what might be the biggest change or trend you've observed in this area of living kidney donation over the last 5 or 10 years from an NHS perspective, and Bob, also from your perspective after Adnan, if you don't mind.
I guess just mirroring what Lisa said. I mean, we really do. And what we always say to our kidney failure patients is, transplantation is better than dialysis. And then when we via living donation has just kind of crept down a little bit, and that's I think that fits in with national trends. I'm not sure. I think living donation in the last decade, I think it's dropped by about maybe 15%, something like that, 15-17%, and it's a phenomenon which is kind of hard to kind of accept, especially with how much work goes into kind of raising awareness. So I think that's probably the biggest thing that we've seen from our perspective, is that it's there's a lot of work to kind of try and raise awareness and to kind of boost the kind of the utility and the benefits of living donation.
Thank you. And Bob?
Well, I guess, as a charity, we work very closely with NHSBT and transplant centers. And I think we bring a perspective of the donor, typically the non-directed donor. And that collaboration has been extremely productive, I think, on both sides. And although it's frustrating that the overall number of non-directed donors coming forward hasn't increased as exponentially as it did between 2007 and 2012, perhaps. It's still making a huge difference. And I think that the UK kidney sharing scheme has been a real game changer to the number of transplants that take place because of non-directed donors coming forward. And I know Lynn's comment about telling people about this, but not being able to sell it. We have to acknowledge, at the moment anyways, we are the exceptions. We're the people that when we hear of the possibility of donating a kidney, and we may be aware of donating a kidney to a family member, but when considering donating to a stranger, our reaction is not one of, oh, I'm not sure about that. It's more one of, well, that sounds interesting. That's something that I might be able to do. And I think that it's normal at this point in time and place that the majority of people are not going to sort of instantly grab and hold that and think that's something they want to do. And we don't need everybody to, we just need enough people to. And that's what we're trying to reach out to, are the people where it is a connection. And the reaction is, that's something I'd be willing to explore and look into. So I don't think we can sell it to everybody. We just need to find the people we don't have to sell it to. We just need to make them aware of it and provide them the resources for doing that. And we've mentioned a few places where there are resources. And I note from, Paul and his situation, there are, and I hope that the transplant centers help people through this, where they have potential donors and they're just not sure about whether it's something they want, whether they have access to talk to people about it in a relaxed environment outside of perhaps a hospital setting, and to think it through, and people with lived experience, so that they can make their own informed decision. So I think all that's where the changes are coming through, and the Robert Dangor program that we referred to, making those resources available so that people can find out more. And I think that is hopefully the next game changer. The other issue we'll face is, if we're successful in raising awareness and finding a lot more people that want to donate, is finding the capacity of the NHS to handle it. But until we can show that there's that demand, then I think it's a step process and a chicken and egg situation that will develop over time. But we certainly need to find more people.
Thank you. Thanks, Bob. I think they kind of, I might interject on this one as well, I think the difference I've seen over the last decade has been the shift in attitudes, I suppose, to non-directed donation, or donating to a stranger. I think it's fair to say 10 years ago, 15 years ago, it was seen as uncommon and unusual. It's certainly not seen as that now, and I think there's been a huge step change, partly hopefully through the work of Give a Kidney, but in kind of non-directed donation is done in every transplant centre across the UK. It is part of business as usual. It's welcomed, and I think the proof has been in the pudding that actually this does not the evidence says this does not put donors at any detriment. And I think the confidence in people not being harmed by donating has really grown, and is fully accepted now that this is a hugely beneficial program for people on the waiting list. So yes, I think that's the biggest change I've seen over the last 10 to 15 years, probably, which is great. And somebody, so Anne's asking how many people are on the waiting list essentially for a kidney in the UK just now, and how's that, and maybe has that changed over the years as well? Lisa, please. Oh, you're on mute, Lisa.
I'm so sorry, Jan. I was completely distracted by Lynn's comment when she was saying goodbye. So, so please repeat the question and I shall attempt to answer it.
Sorry, it was about the numbers on the waiting list. How many people are on the waiting list for a kidney in the UK at the moment, and how has that changed and evolved over the years, or what kind of rhythm do you see with that?
Yes, well, we touched on that earlier, and very sadly, the number of people waiting for a kidney is it's pretty much at its height at the moment, around almost up to 7,000 on the waiting list. And that had come right down because of the initiatives that I mentioned earlier, from sort of 2014, over the last 10 years, we've been really, really working hard and making more available organs for transplant, basically. And then, of course, we had the pandemic, and we can't use the pandemic as an excuse, but it is a reason. And it is a very big reason why we have seen a shift in donation behaviours, and also just people on the list. So it's a bad combination at the moment. We all are working hard on both sides. But what I can say is that we have been working particularly hard on using every available organ for transplant as best as we possibly can, whether it comes from a deceased donor or from a living donor. And in doing that, we have actually improved what we call utilization rates post donation of every available organ. And through the Living Kidney Sharing Scheme, and through the donations from non-directed altruistic donors, similarly, we're working very, very hard indeed to ensure that every single transplant that is identified in an exchange for a recipient proceeds as often as we can. And we've seen a real improvement in that too. So those are two really positive things, that actually the using of the available organs for transplant has definitely improved. And now what we need to do is really work hard on donation rates, both for living and for deceased donation.
Just one other comment, Jan. I think I saw in the chat box earlier somebody mentioned this about pig kidneys, and
Come to that.
I'm sure a lot, it's. I remember the first transplant conference I went to in the States about 18 years ago, and they mentioned things like growing a kidney in the lab and taking a kidney from another species. And I remember thinking, oh, that's probably never going to happen in my lifetime. And it's amazing how, what great progress there is. And the first pig kidney that went into the person in New York was done by a mentor of mine who I trained under, Robert Montgomery. But the one thing that's really important to remember is, one, we are not there yet, and I think we still have many, many, many years before that actually becomes a kind of a reality for us. And two, and this is stated by all the pioneers, all in the United States, including Professor Montgomery and many others who've done these procedures. They do make it very, very clear that these organs will never be as good as human kidneys. And I don't think, if we can get the science right, it will be a safe enough procedure that it's better than the alternatives. But they've all made it very, very, very clear. They will not replace kind of human kidneys, and I think that's really important, because people may think, well, in a few months' time we can just kind of go down to the farm and pick up these organs. I'm afraid it simply will not be like that, and even the possibility of that happening in a hospital is probably still in the distant future.
Yeah. I think I've covered all the questions on the chat. If anybody has any last minute burning questions, now would be a good time to put them into play, or to pop them into the chat, and we'll try to get to them before we finish. I'm just wondering if there's anything from any of the panelists that they would like to mention that we haven't already covered today. Bob.
There was a question from someone about buying or selling kidneys, which of course we know in the UK is not legal. And I've messaged directly back on that. But I don't know, Adnan, it's an area that you've looked at closely, international trafficking, things like that. Is there any comment you want to make on that in general terms?
Yeah, I mean, the buying and selling of organs is illegal, and that is a ubiquitous thing across all countries around the world, apart from kind of one exception. I think Iran is the only country where they've got a regulated system, and the difficulty we have is that people will think about going and trying to secure a kidney through these kind of illegal ways because of the gap in the supply versus demand. And the one thing we make very clear to people is that there's a lot of data that acquiring a kidney through these kind of means, especially when people go abroad, is associated with health risks. And for us here in Birmingham, we published some work many years ago showing the health issues that arises from people who do this. Whether you should be paying people for their kidneys or not is a legitimate scientific debate, which is happening in the US. It's happening across Europe, but that's within the context of a kind of a very regulated system. But no, it's illegal, it's unethical, and the people may be familiar with the case that's been in the papers a lot with the Metropolitan Police and the investigation they did for this person who was trafficked over from Nigeria. There's a lot of focus now on human trafficking for the purposes of removal of organs or just trafficking of organs, and it's a major global issue. And the only way that you will get rid of that is to ensure that there's a sufficient supply of donor organs to meet the demand for transplantation. And unfortunately, whenever there's a gap in supply versus demand, there will always be someone who is willing to exploit it, and unfortunately, that's just the way of the world. So our job is the best way that we can help people is to make sure that we can try and eradicate that waiting list by making sure that we can be self-sufficient in the demand for organs.
If I could just add to, I totally agree with everything Adnan says. The key is making sure our own system is self-sufficient. And actually, what we saw in the time when we had an increase in the available organs for transplants, fewer people seeking this or being desperate enough to embark on risky behavior like this. It is worth, I think, just clarifying a change in the law for the benefit of this audience that came out of the case that Adnan mentioned. So in the UK now, it is a requirement for clinicians working with living donors and with transplant recipients that if they are aware of potentially an unlawful transplant that either has gone ahead or is fully intended to proceed, that they are obliged to report that through the Human Tissue Authority. And so that actually would be subject to further investigation if there were grounds to do so. So just to be absolutely clear that it is always much better if you are in the situation where you're either a recipient or you're close to one who is feeling pretty desperate about waiting for a transplant and even considering traveling outside the UK or embarking on any high-risk behaviour in this area, is please, please, please talk to your clinical team first so that they can advise you, because you're not only putting yourself at potentially a risk from medical reasons, but also a risk of being prosecuted under the law if you come back with a transplant, and that is absolutely not where we want to be. So it is to try and provide additional safeguards for people, for living donors and for transplant recipients. So the really important thing is that everybody's informed very much upfront about that, so you know what your responsibilities are. But it sounds a bit draconian, but it is really, really important so that we can protect the confidence in our own organ donation programme here and do the best for patients. And of course, there are many other reasons why people do travel outside the UK to have a transplant perfectly legitimately. But unfortunately, the focus, as Adnan has said, comes on this very small proportion when it does happen. Jan, the only other thing I just wanted to say, which probably flows a little bit from that, is that that is separate from reimbursement of legitimate expenses for living donors. And I know that there may be those of you on the call who've experienced some challenges around this. Just to be absolutely clear, there is a policy in every one of the 4 UK countries to reimburse people who incur expenses outside medical expenses, obviously, but for, in your own lives, loss of salary, travel expenses and so on. There is a policy in place that you should be reimbursed, provided you can provide the evidence of what your losses are and that they are considered to be legitimate and they are assessed by the commissioners in each country. You are entitled to reimbursement. There is an application process that you have to go through, which might be slightly different in each country, but is principally the same. And your living donor coordinators can give you information about that. It isn't a perfect system. I know there are some challenges with it. When we know about them, either through Give a Kidney or through NHSBT or any other source, we do have discussions with the commissioners. They do get escalated. We do talk to them about how we can improve it. So it is working and it is there for you. So just for you to be aware of that.
Thank you, Lisa. There's just a couple of questions that have come in. So one about roughly how long, it's a piece of string, I think, does it take to go through the entire donation process from first contact with the unit to actual donation? Lisa?
It will vary for the reasons that Adnan said, because some donors may be more straightforward than others medically, and there may be other things that we need to explore. I would like to think that between 4 to 6 months would be the absolute outside, but Adnan may have a different view on that. I think if it's running into a year, I think that's a long time if things are uncomplicated. So I just have to put those caveats on it. But I would say, I would think if you step forward today, you would expect to know that you are suitable and able to proceed within 4 to 6 months, and then there may be some, obviously there may be some scheduling around the transplant itself. But Adnan, what would you say from your experience?
I think 4 to 6 months is probably just about captures, I would say, the vast majority of donors. I mean, if everything is absolutely flawless, then you're looking closer to the 4 months. But people will have certain. It all depends on the complexities and any of the health issues. Again, because safety comes first. If you have a liver problem, we will speak to your liver doctors and get some advice from them. If you are due some investigation that we need to see that, then there will be a delay for that. But it's all mainly, as I think I mentioned earlier, as much as we want to try and go through the process in a timely manner, safety comes first.
Thank you. Let me just have a quick look. There's a question about dialysis. It probably isn't appropriate for this, but I'm sure Paul, if it was Paul, if you want to send that question in by email, we can get that answered maybe for you, or your clinicians will be able to answer that, or your son's clinicians. Anything else from any of the panel that you feel like we haven't covered and we have a burning desire to say before we kind of start to wind up?
Jana, Anne may have left now because she just popped something in the chat, I noticed, as she left, and saying that she does need to persuade her partner to accept her decision. And I think that is a difficulty sometimes, that you've got a very keen donor and a recipient. And my colleague Jen Lumsdaine, who works with me in NHSBT, would say sometimes the recipient can be the biggest barrier to a living donation actually proceeding in a family or a friendship situation. So I would say to any recipient listening to this, if you've got a willing donor, at least have a conversation with them. And also, again, use use the coordinators in your team and the kidney doctors and so on in your team to help you have those discussions, because they can be difficult, but actually they're not insurmountable.
And again, we've talked about it already, but the Robert Dangle Partnership, donatekidney.co.uk, as I said, we do have buddies now. It's a very new program, but we do have buddies, including loved ones of people who've donated, because of course it is really, it can be a very anxious time for a partner who's waiting for you to come round from surgery that actually you don't need as a donor. So they can be really difficult conversations, and partners and loved ones might need some support too, and we really recognise that. So if we can help at all, then do get in touch, Bob or anybody else on this call or watching this webinar after the fact on YouTube or somewhere else. I think we'll probably draw to a close now, but just to say a big thank you to everybody who's attended today, and for all your questions. It's great to have people, coming and actually interacting with the webinar. That's what it's for. We do these, we've done this fairly regularly. We've done this every year or so for the past few years. So we'll be doing more in the future, I imagine. Thank you to the panelists for giving up their time again for us. We always really appreciate your insight and professionalism. So yeah, thank you so much. And thank you to those of you who also made a little financial donation when you booked your place on the webinar today. We really appreciate that as a charity. Obviously, there's no obligation to do that, but if you would like to make a monetary donation, it helps us do things like this and do all the work we do with partners such as NHSBT and other charities to raise awareness and support donors through living donation. I think that's probably everything from us. Again, I'll just give you the web addresses for Give a Kidney, which is www.giveakidney.org, and for the Robert Dangle Partnership, which is www.donatekidney.co.uk. And I'd encourage anybody who's going through the process to get in touch with the partnership to help be supported through, if you would like some support through that process or beyond. And I will leave it there. If you're watching this on YouTube, please do like and subscribe to our channel. All our other webinars are on YouTube. There's ones around ethics, there's ones around the science of transplantation. There are other kind of frequently asked question type webinars, a very brief introduction to living donation at a very basic level. So please do have a look. And if there are any webinars you would like to see us do in the future, please do get in touch with Give a Kidney, and we'd be happy to listen and explore what we can offer. So once again, thanks to everybody. Enjoy your Saturday and your weekend, and hope to see you again soon.